Okay, let me also add the committee's thanks to our speakers. And then we have room for public comments, and I'll start with the comments in the room first, if there are any. And again, please introduce yourself and any institutional affiliations.
Hi again, Judy Staffa from FDA. Thank you all for such a wonderful, interesting day. But I'm going to try my best to channel Doug Throckmorton, who wasn't able to stay. A lot of interesting topics have emerged, but I'm going to advise the committee that you might be well served as you think of the total realm and gamut of all the things you've heard and are thinking about today in this very complex clinical and abuse situation, to try to go back to the statement of work, because that is hard enough, frankly. So I'm just going to encourage you, as you think about all those things and have your own discussions, to be trying to at least separate what you see as covered under that scope of work versus all the other really important moving parts. And cannabis comes to mind as kind of probably the biggest one I heard today. And try to figure out what you can tackle in the time you have. So all interesting, all important, but I think you'll be helping us more if you can try to figure out what are the most essential things to stick within that scope of work, because again, that in and of itself, I think is very challenging for the amount of time you have. So thank you.
Thank you. Robbie, do you want to read a comment from the internet?
Sure. Adding to, these actually came in earlier, so adding to what was mentioned on pain assessments to be moved away from numeric scales, the push for opioids based on...
Goodbye.
Okay. The push for opioids based on numeric scales is still a problem nationwide, and many hospitals administrators are still very fixated on placing numeric scales onto orders to avoid, quote, duplicate therapies, end quote. While the Joint Commission's push for pain as the fifth vital sign is not the reason for the opioid epidemic, and they have pushed back saying that they never required numeric pain scales tied to orders, many institutions still struggle with pain management with opioids and doses tied to numeric scales, basically leading to a one-size-fits-all generic pain order sets regardless of cause or indication.
Thanks. We have a comment from the audience.
Hi, Joanna Starles from Einstein and Montefiore in the Bronx. Just thinking about the intermediate outcomes that are important here, and in particular the analytic framework where you had the adverse events coming off on the bottom. It strikes me that if the goal is to reduce unnecessary exposure to opioids in the community, then the absence of harm or the absence of adverse effects might be the most important outcome. So it's unlikely that you're going to see, I would think, a improvement in mortality by reducing the dose from 30 to 50. But if you don't find that there are significant harms, or if there's a body of evidence supporting that there are probably not significant harms, that might be an important intermediate outcome.
Okay.
Thank you.
Thank you. Robbie, any other comments?
One or two more. One commenter asked to please be sure to use inclusive language and include provisions for training of other disciplines. Nurse practitioners and PAs are increasingly responsible for outpatient prescribing, and nurses for education of patients regarding medication use. There was a further corollary comment that said, requested that the panel and FDA consider working with clinical nurse associations that work with and represent not only their members, but hundreds of nurses who are exceptional nurses in the area of pain management.
Okay, thank you. Any other comments from people in the room? Okay, Robbie, another comment from the audience?
Two more. A very short one. Need to focus research on the referral component of screening, brief intervention, and referral to treatment, the least studied component. And finally, the last comment, care must be taken to be clear that some patients, based on a number of variables, will have higher than average opioid requirements, and determination is based on individual assessment. Case in point is the fact that prescribers have to appeal to insurance companies to get approval for patients to have more than 90 milligram morphine equivalents, as insurance cite CDC chronic pain guidelines.